So welcome to our webinar series on data and measurement in youth mental health. If you are joining us, if you've joined some of those series before, then you're not new. It's not new to you. And I'm probably not new to you, but I will introduce myself a little further. But before I do that, I do want to make note that we have translation options available, but not voice translation, unfortunately, but you can access the translated French captions. If you just go to the bottom of your screen, there should be 3 dots on the right. You can select those and then select translations, and it will generate. And if you have any issues, you could let me know in the chat, and you can feel free to ask your question in English or French, and we will also provide translation. I won't, but we will. And yeah, without further ado, I'm Alyssa Frampton. I'm the coordinator of the CIHR Grant in Youth Mental Health. We're a pan-Canadian networking and knowledge translation grant. And we're aiming to provide opportunities for the youth mental health community across Canada, and also through this series in particular globally, to engage, network, share developments, build collaboration around data and measurement, all that good stuff. And through this series, we're really looking to better understand the current and future landscape around data and measurement. We want to understand what's happening, where are the gaps, what innovations are existing and filling them, and how do we move forward together and in a collaborative way. So far, this series has touched on why data and measurement matters, the basics of having a learning health system. We've also talked a little bit about responsible measurement with Dr. Antal. We talked about considering the personalization and the standardization, and also thinking about some of the things we might want to consider around e-mental health. We had Dr. Gina Dimitropoulos and Jason Gonzala who spoke 2 weeks ago, so that will be up on our YouTube soon. I'll add to the chat in a few moments just the website link for the Catalyst Grant, and also for our YouTube channel, which has all of the past series and which will have all of the future series as well. And this is the second last webinar before we'll take a small break in the series, and we'll come back in September with a French series. And lastly, before I introduce you to our speaker for today, we do welcome you to add questions into the Q&A or the chat function as the presentation happens. I also have a few questions that folks had submitted ahead of time, so we can start the Q&A off there. And if you want to save your question until the end, that's also totally okay. You can opt to raise your hand at the end as well, and I can give you the ability to turn your mic on if that's more comfortable. So I will introduce our wonderful speaker for the day. So Anne John is a professor of public health and psychiatry at Swansea University Medical School. She's a clinical epidemiologist with a background in public health and general practice. Her focus is on suicide and self-harm prevention and children and young people's mental health. She's a PI and co-director of DATAMIND, the MRC-funded HDR-UK Mental Health Data Hub. And leads a research program with a focus on mental health data science, including the MQ-funded Adolescent Mental Health Data Platform and the Suicide Information Database. She's passionate about the translation of research into policy and practice, and chairs the National Advisory Group on Suicide and Self-Harm Prevention to Welsh Government. Anne has led and been involved in the development of several government and NHS commissioned reports, policy documents, and community resources, including those for the education sector, particularly in relation to mental health, self-harm, bullying, and attendance. She's contributed to numerous advisory boards and expert committees, and has advised on several media storylines, including Coronation Street and This Is Gonna Hurt, in relation to the responsible depictions of suicide. Anne is a trustee of MQ Mental Health Research and a fellow at the Faculty of Public Health and Learn Society of Wales. And so we are really excited to have Dr. Anne John here to speak to us today about big data and youth mental health. So I will pass it over to you, Anne, and shut my camera off.
Thanks so much, Alyssa. That was quite a long intro. I'll make it much shorter next time. I'm just going to share, just going to share my slides. So if those shared.
Yep, perfect, we can see.
Wonderful. So I'm going to talk today about lots of the sort of what we call big data for youth mental health, which is effectively using electronic health records, but also other administrative data, and some of the issues with that, but with a focus on translation. So how do we make the work that we do make a difference in the real world? And I guess, as well as being a parent of teenagers, I'm also a governor in a school and worked in primary care. And I think all those things help inform how I think about the work that we do. So I guess from my perspective, research is great, novel findings are great, but the thing that makes my work meaningful is the translation of that work into policy and practice. Now, pre-COVID, it used to take about 17 years to get research into practice. Things have sped up, but there can still be, techniques for making that happen. So whenever I talk about youth mental health, within the UK, but I think particularly when we're talking about it beyond the countries that we work in, it's good to have an awareness that young people, children, youth, all those terms mean different things to different people. So, when we talk about youth, we're thinking about that period where young people are maturing, there are changes in brain structure, you've got synaptic pruning. There's also, it's a period of psychological development. People are developing their sense of self, independence, self-esteem. We know that young people, their decision-making is quite different to ours. And this is where that's evolving. They're learning emotional regulation. They're much more sensitive to peer rejection than we are. You can measure that in psychological experiments. And because of that, things like bullying, feeling different to others, things around gender identity, those can be particularly impactful on the mental health of young people. And they're also experiencing those transitions. So in the UK, we have services that go from child and adolescent to adult at the age of 18. In some places, they have services that go from 14 to 24. I personally think that's better design, because we very much, if young people have been supported in their mental health through child and adolescent mental health services, at the very time that they may be leaving home is the very time we change their access to services. So there's lots of transitions around that time. So I tend to think of early adolescence 10 to 14, adolescents 15 to 19, and then when we do studies, we tend to do them in 10 to 24-year-olds. But I have seen studies where we see young people up to about the age of 29. And I guess at this point in history, we've got the largest number around the globe of young people, so 2.4 billion 10 to 29-year-olds. And that's, and all those reasons together is why it's so important. And what are the concerns in youth mental health at the moment in society? There's the idea that we're labelling children and young people, we're medicalising human experiences. So think about, gaming disorder or social anxiety. There's a big concern in society that we're taking the usual ups and downs of life and turning them into disorders. And some of that is because we've lost some collective memory. So with the change in society, so families don't live so close to each other, that sort of, we have an expectation often that young people are always going to be happy. So the issues are we pathologizing normality? And is there a real crisis in mental health? Now, 10 years ago, I was doing studies in administrative data. And by that, I mean the data that gets collected as, not for research, but as people go about their daily lives, their contacts with health services, their contacts with the criminal justice system. And we looked at prescribing of antidepressants and self-harm admissions, and both were increasing. However, when you're looking at electronic health records, if there was poor access, so we know that lots of mental health problems in young people were missed, they weren't recognised, people didn't present because of stigma. So those increases may well have been due to better care. And I think it's always worth, when you're working with routinely collected data, understanding that changes may be, that they don't always indicate that things are bad. So if you think about repeat self-harm, we know that repeat self-harm is associated with poorer outcomes, both, morbidity, so illnesses, but also mortality, and not just mortality from suicide. But when we're looking in routinely collected data, so it's thinking about what's being measured, it could be that we've improved help seeking. So these are the sorts of things that a decade ago we were trying to unpick. However, what we've seen in cohort studies, that's the sort of research that we cut our teeth on. So when I was an early career researcher, it was cohort studies where the data is collected for research. Cohort studies do show increases. So you can see it in the blue graph about probable mental disorders from a big survey that's carried out in England. But also in the second graph, you see those increases across much more emotional-based symptoms, so persistent feelings of sadness or hopelessness. Now, there are certain cohort studies that show quite definitively, with the best validated measures that we have, that anxiety, depression, and self-harm are increasing in young people in most Western countries, and particularly in older adolescent females. But there are others who talk about, should we be focusing on diagnosis or should we be focusing on symptoms? And that's for two reasons. Complexity is increasing, and also often it's transdiagnostic symptoms that are important to people and patients. So is this true? I do think there is a true change, or are we inflating what we're saying? So one of the things when we think about self-harm, so this is, in the UK, we have what we call the Adult Psychiatric Morbidity Survey, which is a probability sampled survey. So it's the closest we get to looking at what's happening in the general population. It's run every 7 years. And what we see, when you're looking, what this graph is showing you is that more young people self-harm to manage their feelings than older people. And why that's important is about whether we have a generation of young people going forward in life who are using this behaviour to manage their emotions. And is that one of the things that's driving this increase? So is there a youth mental health crisis? We know there's a problem. We see increasing trends. We know that 45%, to me, that was shocking, of the burden of disease in 10 to 24-year-olds are due to mental health problems, and that young people with mental health problems go on to have poorer outcomes in life, be that multimorbidity or poor attainment and unemployment, poor attainment in school and unemployment. We know that suicide is the leading cause of death in 15 to 19-year-olds. Young people don't have the highest rates of suicide, because if you think about older people, so middle-aged men in the UK have the highest rates of suicide, but they're also dying from lots of other things like cardiovascular disease and respiratory disease. So suicide is not a leading cause. But in young people don't really die from those sorts of chronic conditions. So suicide is one of the leading causes of death in young people. There's a lot of stigma. There's a lot of stigma related to mental health, and there's a lot of ambivalence in relation to young people. And all these things conflate to create a sense of a crisis. So it's a neglected area of research. MQ, where I'm a trustee, did a piece of work a few years ago looking at funding for research. And I think it was something like, every £6 spent in cancer, there was £2 given to mental health research. I think that has changed a bit the last few years, but a neglected area means our understanding is more limited. And young people have poorer access to care. And where you've got increased awareness, we know that the population is much more aware of when they're unwell in relation to mental health. But when you put that combination of knowing that you need help and poor access to care, that can also create a sense of crisis. So in the middle of all these concerns, why use data linkage? Why take all this routinely collected data that happens as people are, going about their daily lives? Why use that? So when we think of more traditional studies, where you go in and you do a survey, then you might ask people to come and you might collect things from them, that actually presents a bit of a burden to participants. And people most likely to experience poor mental health or suicidal thoughts may be less likely to take part. So, when we're doing research in schools, often the very children that are at the highest risk will not be there. So so there's an issue around recruitment to studies. Many of the measures that we use in cohort studies are self-reported and are subject to bias or recall bias. People, particularly for self-harm, are often lost to follow-up. So what we're finding is just what's happening as we're doing our study. We don't know what happens in the future. And then often with these sorts of studies, it can be very hard to, underserved populations, so Gypsy Roma traveller populations, people from ethnic minorities. We continuously see, both in cohort studies and trials, that they're not represented. Or if they are represented, there aren't enough numbers to find out anything meaningful. And those problems are partly overcome through using linkage. Now, and by that, I mean both when we just do electronic cohorts, so we're just looking at routinely collected data, or where we take a cohort study and we follow people up using their linked data, so they're never lost to follow up. The other thing about this sort of data is that it really speaks to policymakers. It's really about the world that they're governing. And so the ability to make change is huge. The opportunities are much more than I've seen in other work that I've done. So I do a lot of my work in what's called the SAIL data bank. And that is, so Wales is a devolved nation of the United Kingdom, and we've got a population of about 2.4 million. And within the SAIL data bank, we have a population spine, and that can link to health data, GP data, hospital data. We've linked to court data, university student data, and we do that using a split anonymization process. So the identifiable information is split off from, the things we want to look at, sent to a trusted third party. So we never know who those people are. And they create what we call an anonymized linkage field. And for every individual in Wales, that anonymized linkage field is the same. And so we can link across individuals in different data sets. And that allows us to do a lot of at scale. So it includes underserved populations. We do studies in hundreds of thousands, if not, 2.3 million people. So one of those studies that we did was about school absence and exclusion in young people who's, I'm going to focus on self-harm, but we actually did it in mental health problems as well. So we know that children who are absent or excluded from school have poorer outcomes in later life. But most of the studies done previously were quite small. They were based on questionnaires or interviews with children in school. And as I said before, if you're doing a questionnaire in school and you're looking at absence and exclusion, those children aren't there. And you don't know who they are. So they're less likely to participate and more likely to drop out. Now, when people understood that attendance was important, what happened in schools in the UK was we started handing out, 100% certificates, 100% attendance certificates. We started rewarding good attendance without understanding why for some young people, poor attendance wasn't about an unwillingness to go to school. It was a consequence of other issues. So what we did was we created an e-cohort study of 400,000 children between 2012 and 2016. And we looked at any mental health. I'll show you all the disorders we looked at: mental health, neurodevelopmental, or self-harming issues, diagnosed up to the age of 24. So not just when they were in school. And the reason we did that is because if we know it can take up to 10 years from experiencing symptoms to getting a diagnosis of anxiety or depression. We know that some mental health problems like bipolar disorder or schizophrenia, they will generally not be diagnosed until people are in their early 20s. But they're prodromal, their pre-diagnosis effects are very likely being felt in school. So we took data from the absence and exclusion data from the education data set, and we linked it to electronic health records, so primary care and hospital data. And we looked at all these conditions. So depression, anxiety, self-harm, neurodevelopmental disorders, and drug and alcohol use. And very unsurprisingly, so the pale blue line is the absences, in this case it's absences, of children who didn't have any of those records in relation to those conditions. The red line, consistently across all of them, showed that young people had higher levels of absences and exclusions who would go on to be diagnosed with these conditions or have them while in school. And that sort of turns the argument on its head, doesn't it? Because what you're sort of saying is, actually it's not about improving attendance and reducing exclusion, becomes less about, you know, fining parents, and much more about providing early intervention and support to these young people. So when we looked at absences, we saw rates were consistently higher in those with a record of self-harm across all ages, but it increases with age. And pupils with a record of self-harm were twice as likely to be absent if they were in the most deprived quintile. So, you know, it's all the things that, you know, what I often say to my team is we're not doing rocket science. If you ask teachers, if you ask parents, they know these answers. But what we can do with this data is demonstrate it really clearly. And if children had special educational needs status, it reduced the likelihood of absence. So interventions mattered, because if they have that status, then things happen. Now, the things that are important in the work that we do is that over time, we've developed validated code lists. So, you know, when you're looking at coding systems, particularly in primary care, what we've done is we've linked electronic health records to cohort data with validated measures. And we've identified who's got records in their system and what are the best codes to use to identify those people. So all our code lists are freely available. So, you know, we improve those FAIR principles. You know, it's really findable and discoverable that we can all be measuring the same things if we're using the same code list. And you'd be surprised when you look at this sort of research, how many people are using different, you know, that they say they're measuring the same thing, but they're not, because their code lists are so different. In terms of exclusion, we saw similar things. Rates were about 7 times higher in those who self-harmed. And where you see that drop between 15 and 16-year-olds, what we think that's to do with is off-rolling. So in the UK, we have what we call GCSE exams, and schools, you know, they're measured on their attainment. And so some children are off-rolled from the school registers, and that's what we think that is. Much higher with deprivation, and boys with a record of self-harm were twice as likely to be absent compared to girls. So what does this tell us? Children with mental health problems and children who self-harm, children with neurodevelopmental disorders, they spend less time at school. Now, we're not saying that absence and exclusion causes these things, it's bidirectional. But it could be used, this is routinely collected by schools, it could be used as a potential indicator for current and future need. It could be used to target assessment for early intervention. And absences and exclusion can be part of school-based mental health prevention strategies. It's a real thing about reframing how we look at attendance. And, you know, having those things in school where we're teaching social and emotional regulation, relationships, self-help strategies, awareness of when to seek help. And as a result of our work, we tried to, you know, really push Welsh Government to for schools to use that to highlight children in need of early intervention. But what happened was in Wales, children were considered to be persistently absent if they were absent for 20% of their time, the time they were meant to be in school. As a result of our work, that changed to 10%. And what that means is that more children will be highlighted as persistently absent and in need of support earlier on. And I think, you know, with the sorts of data that we're using, that really shows us and really speaks to policymakers and practitioners. A similar thing happened when we looked at self-harm in children and young people across settings. So, we looked at emergency departments, primary care and hospital admissions. We saw those increases that you would expect. Of 10 to 15-year-olds who presented to emergency departments, about 3/4 were girls. And one of the things we found, and you can see it in the bottom two graphs, is that females were much more likely, so this is, young people up to the age of 18, females were much more likely to be admitted to hospital than males. Now, the reason, so we had national NHS guidance in the UK at the time that any young person, any child presenting to the emergency department with self-harm should be admitted overnight to PEDS to ensure they got an assessment. So you would have expected that to be roughly the same. It wasn't. So then we thought, okay, girls, young, females are much more likely to self-poison, whereas boys are much more likely to self-injure. It may be that, poisoning requires monitoring. So is that why they're being admitted more? No. What we found was that differential in admission was there regardless of method. And so what we ended up concluding was we talk a lot about how young boys and men should seek help more. What we don't talk about is how healthcare systems, other systems might be responding to males differently than females. And that's what that admission might be about. We've done, lots of work on social media and online imagery. I guess from my perspective, I'm always, when I talk about self-harm, I'm always asking the audience, it's all social media. You hear that about mental health problems as well. It's down to social media use. We always emphasize there are harms and benefits to social media use. So, the harms are people often get support, there's a sense of community. So for more marginalized groups, say like LGBTQ+, they can find other people online. It can be a coping mechanism, it can reduce isolation, it can reinforce how you seek help. But there's also those things of online bullying, internet addiction, normalizing self-harming behavior, sharing of information about methods. However, although we can talk about harms and benefits, then it's not a dichotomy. The impacts change for the same individual at different times and between individuals. And I guess one of the things I'd say, it's not going away. It's increasingly used to communicate distress. And I do lots of work with industry and Samaritans, which is a charity in the UK, talking about, it's one of those settings for young people. I see it as a setting in much the same way that we think of school, family, the online environment, but it's one of those settings where there are very few adults. And one of the things that comes across increasingly in our work is that young people want agency over what they see. A lot of, they can, a lot of algorithms push content to young people. So when we think about suicide-related internet use, about 1/5 of deaths of suicides for children and young people, there is suicide-related internet use. And that could be searching for information about methods, posting messages, with suicidal contact or being a victim of online bullying. So we did a systematic review looking at cyberbullying and suicidal behaviours. And I guess this is, when we talk about measurement in youth mental health, we're often talking about, how do we measure a symptom? How do we measure a diagnosis? How do we measure mortality or other outcomes? But what we found when we did this systematic review about cyberbullying was there was literally no consistency about the diagnosis, about how you define cyberbullying. And I think what that says is that one of the things you should do before you do any study is look at how other people are measuring what you're interested in and harmonise. It could be that you have a very particular aspect that you're looking at, but it's really good to incorporate measures that are consistent across studies. And the reason that's important is so that we can look at a group of studies and get a bigger answer. Whereas at the moment, where everyone's, developing their own questionnaires, asking about cyberbullying with a single question, and lots of the questions were phrased quite differently. So if you want to be doing good science in this area, we really need to be thinking about how that measurement is consistent. We need to be really transparent about what we're measuring and what methods we're using. You'd be surprised at how often that doesn't happen. So based on all that work, one of the other big data studies we did is so in Wales, the School Health Research Network every 2 years does a survey of every child in school. And we took that data set and placed it into SAIL and linked it to electronic health records. So when we did that review, most of the studies that we looked at were cohort studies, and they were mostly cross-sectional. There was very little follow-up. And so what we did was we looked at children who said they'd been bullied in school in the survey, and then we followed them up to look at who self-harmed. We saw a relationship, but one of the few times it had been done in a longitudinal way. And one of the things from the survey that came up as strongly associated with that relationship was feeling lonely over the summer. Now, we weren't expecting that. If I was being entirely honest, we'd been doing lots of research on loneliness, which is why we chose to include that in our models. But loneliness, feeling lonely, the actual question that's asked was basically about feeling lonely over the summer holidays. And that's a very translatable issue. It's something we can do something about. Whereas often, things like poverty, they can be much harder to address. And so that was very much picked up by policy colleagues. So one of the pieces of work we're working on now is, so it's about to come out in the British Journal of Psychiatry, is we linked university student data to electronic health records, and we took students between the ages of 18 and 24 in undergraduate courses and had population level controls. Now, often when I'm talking about university students, what I'm saying is that basically, if young people get to university, their mental health is often better than the general population because young people who don't make it to university, often there are mental health problems associated. You know, there are higher levels, not all of them, but there are higher levels. And what we found was that in general, that was true. But there were trends over ages for things like alcohol use and self-harm and depression, where young people not in university, their trends were better, they improved more than young people in university. And that could be for all sorts of reasons. It could be about debt, academic pressure, losing your peer supports. But one of the things that working with big data does is it gives you population level controls. And, you know, we don't have that. So I guess you working in that sort of data is really important for, you know, novel linkages, providing evidence in places where there isn't a lot of evidence and informing strategies. And it really speaks to policymakers across different departments. So when you're talking about multidisciplinary research, you're often speaking to multidisciplinary policy departments. You know, other things we've highlighted, you know, there's been a big focus in my field about people presenting with self-harm to emergency departments in hospitals. Some of that is about levels of risk. Some of that is about thinking, you know, a lot of this work is based in mental health services and by academic psychiatrists. However, what we found is that GP, primary care, is the place where most people present. And I think what this data shows you, the thing about doing this, and we saw the same when we looked at healthcare contacts prior to suicide, and what this data shows you, and what you can measure, is what were those contacts for? Well, unsurprisingly, they were for mental health, injuries, poisoning, accidents. And what the graphs at the top show you, so the red lines in particular, is that these myths that people don't seek help prior to suicide are myths. What we found across men and women was that contacts with health services escalated prior to death. And those are opportunities for intervention. So, you know, things that we think we know, you can really address with real world data. So, you know, one of the things we have in the SAIL data bank is what we call depth of data. So we can link across really novel data sets. So one, we linked health data to family court data. So that's public law proceedings. So where parents, which is safeguarding. So, you know, children are at risk. It's about their safety and welfare. And public authorities take parents to court about, you know, the care of their children, but also private court that are usually as a result of disagreements during divorce and custody cases. So we linked that data. We did it for anxiety and depression in children and found much higher levels of anxiety and depression in both private and public. So private court cases, we don't do a lot to support those children. Whereas in, you know, care experienced children, children in need, children in public court cases, although I think, you know, we fail them and their outcomes can be really poor, we are increasingly putting measures in place to support them. You know, with our project, the next stage of this project is we've looked at self-harm. So, you know, we take that CAFCAS court data, we link it to health data. We also, which also meant that we had matched controls, and we looked at, you know, incidents of self-harm and what happened over time for children up to the age of 18. And what we're talking about is, 21,000 children in contact with CAPCAS in, a population base of 700,000. So these are really, really large scale studies. Those in private court were 3 times more likely to be from more deprived areas. And I think, there's a general consensus that it's richer parents that go to court during custody battles. So you'd be surprised at how much you can contribute to the evidence base. And what we found was that rates of self-harm across all services were elevated. And for those in public court, where it's safeguarding issues, they were more than 5 times higher. And similarly, time to self-harm. So for public court, it was much higher. So how do you translate that? So that's about highlighting it's both private and public court cases, tailored outreach, thinking about integrating health and social care and suicide and self-harm prevention, support beyond court involvement, and making sure that these issues are highlighted in suicide and self-harm and mental health prevention policies and practice. So it really highlights the complexity of needs of these children. So over time, we've done a lot of work. We had a cluster of suicides in South Wales, and we were able to look at people who had self-harmed around the time of the suicide cluster and follow them up over 10 years. Now, that sort of research is really challenging to do if you're going back to people in person. So that is the beauty of this sort of work. But I guess I don't want to detract from work that's based on smaller populations. We still do that. We do qualitative work, we do reviews, case reviews of case reviews, thematic reviews. And these can highlight all sorts of common themes across suicide in young people. And so I guess, although we think big in the data that we use, I think the answers are found in all the different research designs. So I'm just going to say a little bit about COVID. So there was lots of concern about increases in suicide following COVID. You saw it all over Twitter, increased by 200%. We didn't have near real-time surveillance then, so we didn't know. And so it was really being used to by anti-lockdown lobbyists. So I was part of the International COVID-19 Suicide Prevention Research Collaboration. I was on the steering group. I was also co-led 2 studies, one of which was a living systematic review, and one was about suicide trends. Now, we collected suicide data, real-time suicide data, from 21 and then 35 countries. And I guess it really highlighted that measurement issue because everyone measured suicide in slightly different ways. And we always had to go back to the most common denominator, particularly when we looked at methods. So my last few slides, I'm going to stop speaking soon, is how do you make those connections to translate research? And I guess pre-COVID, I had advisory roles. I sat on funding boards. Once you've built that expertise, once you've shown that you can communicate what are sometimes quite complex research findings into words that people understand, people trust that you won't over-egg your research, so you can, if you're suddenly in front of people that make a difference, it can be very tempting not to put up those what are the limitations of what I'm doing? But I think over time, if you do that, you build that trust and understanding that you're presenting the evidence, other people are making the policies. So during COVID, I sat on a number of UK government advisory groups. And I guess a lot of that, I think, comes from communication, but also trust. And I guess since then, I now sit on ministerial groups about mental health in schools and mental health in universities. I think it's really important to be able to communicate the uncertainty around science. You know, very rarely will any of us be a part of a study that gives the true answer. Research is always approximations around the truth, and you build that evidence base. So it's really important, I think, to learn those skills of managing uncertainty around what we find. And I guess it's also thinking about what is it when you're giving advice? And I think it's understanding we're not elected officials. We can be unfamiliar with broader policy contexts. So I think you can, you know, you have to think out for yourself where you sit on that. I'm here as a scientist talking about my study, or I'm here as an advocate. You know, and I've held both roles. And I think that was, you know, sometimes that was lost amongst all the scientific debate during COVID. But evidence doesn't implement itself. Policymakers may not always understand the complexity and uncertainty of what we're saying. And so, as well as engaging with policymakers, within government, there are chief medical officers, there are chief scientific advisors, there are people from our backgrounds in roles that we can communicate with. And understanding that translation and implementation are, you know, it's a science in itself. And, you know, to bring people with you, particularly from underserved groups, you need champions in those communities, you need to use co-design, you need to think about the unintended consequences of what you advise. You know, in the UK, we had Eat Out to Help Out during COVID. And lots of studies have shown that that probably increased infections. So lots of scientists don't agree. You know, there are people who advocate that, you know, our role is advising government and informing the public. And then there are others that say we should advise, but politicians decide. So are we bridges, or do we just go, say our piece and leave? I think the other thing to do is it's really important, media engagement is really important, but online we should model behaviours, and I don't think we always do. So I guess there are two models for making a difference. You can, you know, I'm part of two grants, Administrative Data Research UK and Wolfson, where built into the grants, we've made partnerships with government. So we work with the knowledge and research people working in government. And then the other way to do it is over time, you will build trusted relationships with policymakers. So I'm talking civil servants and politicians. And, you know, so long as you maintain that trust, that's another way to take it forward. So on the other hand, I guess my final thought on translation is that timing is everything. You know, the times when we've made the biggest difference to policy is when we're doing something that politicians are thinking about and thinking of legislating on. And I guess that's where, and I've listed the studies that we've had there, where if you build those relationships, you'll understand what those things are, and you can feed into the development of strategies. Always respond to calls for evidence, always respond to the development of strategies, and make sure that that evidence is feeding into those things, because I think, you know, evidence-based policy making and practice is absolutely the way to go forward. So that was as much as I was going to say.
Thank you so much. I'm going to put my video back on. Oh, thank you so much, Anne. Well, first of all, wow, the UK has a lot of data. I think that's like my mind's blown in thinking about how much data, like you're even the way to make those linkages. Like I immediately was texting and being like, do we have this? Like, what is this is a crazy amount of data. So I think, yeah, thank you so much for sharing. And also when thinking about like the policy implications, I love that you went back to that first slide with the translation and like how do we not get lost in the translation and actually move it into that implementation piece. So thank you for bringing us full circle from how do we, get the data, collect the data, and then also moving into that policy. So I really think that was, really appreciate that. I'm wondering if folks have any questions they want to write into the chat. You can use the chat function or the Q&A function, whichever one you'd like. And then I also had one question about how the SAIL platform came together to be able to have all of these different data sets to be able to do this linkage work.
So it wasn't always easy. So SAIL's been around for about 14 years. And in the beginning, it was literally building those relationships with each general practice. And then, so you almost saw it as growing geographically. And then I can remember in the beginning, when we were submitting papers, sometimes reviewers would come back and go, what's that? Where's Wales? And then over time, trust was built. And so, what sometimes happens is that people will come to us. So we just recently did, the Criminal Justice Department recently shared a year's worth of the Wales prison population. And we linked it into SAIL. And that was because they wanted to understand a very particular problem. But then what happens is when people understand that we do that under the 5 safes, so it goes through ethics, the researchers have to do a course to be trusted researchers, the data is accessed remotely. So there's none of that sending data over email and university servers. And when they see what can be done, then they often deposit their data within the data bank so people can apply to use it. And over the years, I've seen that happen so many times. At first people are very nervous, and then over time, when they see the answers it can give, they want to see it used.
And thank you for sharing that. And I think we're, having a lot of conversations about data platforms and bringing data together here in Canada. So I think, and this does come up a lot is, how do you get buy-in? How do we bring people on board as we're doing that? How are you going to gain trust of organizations to want to deposit data into that? So thank you for sharing that. I'm just going to go and look at my screen. Any other questions? I have like 100 questions, but I also know we're almost at time. I have one other question about the types of data specific to youth mental health, and how you were talking about the university mental health work and linking that back. And so what are the types of data specific to youth mental health that comes out, or specific to mental health that comes out from those university pieces?
So basically, sometimes the data sets that we work with they often won't have a lot of mental health related data in them. And so what we use them for is to identify people in that cohort. With the prison data, we did actually have all their health data. But in universities, if you think about, you know, the wellbeing services and all that, they don't really keep records that you could link. So what we had to do was go to health records.
Okay.
So where people had accessed, you know, general practice or gone to hospital to look at that. But what you do get from it is, you know, year of study, had they dropped out, where they were living, that sort of thing.
No, that's really helpful to know. And I think we're looking at a study looking at university health data, and I think also trying to figure out what are the things that are even being collected right now. And I think, you know, that's where this question's fueled from, and that we're doing some of this as well.
So what we tend to find is that sometimes you have to work with people to get their data, you know, one, linkable, but two, also consistent enough that you could do something with it. So when we first worked with the Churn data, we weren't with the school survey data. When we first tried to link it, I think our linkage rate was like 9% of the cohort. So then what we had to do was go back to them and basically they had to very carefully go through all the fields we use for linkage, like name and age and all those things. So I think, and we've worked with charities as well. So I think sometimes in order to do the work, you have to do like the data management work beforehand.
Thank you so much. We have one more question in the chat. Could we maybe answer some, and then we can clue up? But the question is about, have you been able to make changes to what data or how data is collected in administrative data? An example coming to mind was from video was around the collecting data on sex in most data sets vis-a-vis collecting data on gender and self-identified.
So totally agree, that's really important. So we've got, so I'm very specific when we write our papers that we write sex at the moment, because that's what's being measured. People are entered as males and females. So we've just recently got funding to look at administrative data and see where gender might be recorded and whether we could create an algorithm that identified different people in different data sets. So in the education data set, there is some recording. And in the Churn survey, there is some recording of gender. Personally, I think what we're going to find is that we cannot create an algorithm that that identifies enough people to be usable. And then, so to me, when you do that work, that's when you go and you say, this is really rubbish, which means we've got no idea of the needs of people. And so that's when you push to make change in the administrative data. So you really saw it with ethnicity during COVID. So when when we'd all noticed that lots of the photos of healthcare workers were from ethnic minorities, we all went to try and use routinely collected data to look at it. And it was really, really difficult because ethnicity is so poorly recorded. And so there's been massive changes. I don't know if they go far enough, because, I'll give a good example for this. So the best ways to record ethnicity are for people to self-identify. But, I took my 14-year-old daughter to an ENT appointment and she had an iPad shoved in front of her to identify her ethnicity. She's never thought about it. She's mixed. She was completely like, I have no idea what's going on here. So I think we've got a long way to go with ethnicity recording, but we are doing work on gender.
Vidya, thank you so much, Anna. And Vidya, I know you've also put your hand up, and so I gave you permission to talk, so I didn't know if you wanted to, had something else you wanted to share, chime in.
Thank you, and if I can just but since you gave me, thank you so much. And this was just an incredibly amazing presentation, so much inspiration for some of the work we're about to do in Canada with respect to data platforms, and definitely look forward to being in touch. Thank you. Really, really inspiring.
Thank you.
Yeah, thank you so much. So this is fantastic. I don't want to take any more of your time. We are a little bit over from when I had asked you to come. And so thank you so much again. And I will follow up with those who are in attendance, and I'll follow up also and with the recording and by email after. Yeah.
Thank you.
Take care. Thank you so much. And we will talk again soon.
Yeah,
Bye-bye.
take
Have
care.
a great evening.
Bye.